evening, doctors. At the outset, I, on my personal behalf and on behalf of ERIS, welcome you all to this webinar and expert panel discussion titled Metabolodiuretic Promise of Dapagliflozin, the Sweet Spot in Heart Failure. I also extend my sincere thanks and deep gratitude to all of you for graciously accepting our invitation to join us to be the part of this webinar. And I'm sure that your presence will add the academic flavor to this initiative. Today we are joined by two eminent and illustrious international personalities. Besides being the dexterous clinicians, they are academicians, they are researchers, they are excellent teachers, they are excellent speakers, and moreover, they are men of human heart. Dr. Darren McGuire and Dr. John Mcmurray. I, on the behalf of all of you, welcome both of them. Welcome, John Mcmurray. Welcome to you.
Thanks.
To further add to the academic texture to this webinar, we have two greatly honored, luminous and preeminent panelists, Dr. Vijay Viswanathan and Dr. J.S. Hiremath. One is the doyen in the field of diabetes and the other is the maven in the field of cardiology. Now let me have the pleasure of introducing to you today's speakers and the panelists. Can I have Dr. Map? So we have Dr. Professor John Mcmurray. He is a professor of medical cardiology and deputy director of the Institute of Cardiovascular and Medical Sciences. He is the honorary consultant cardiologist at the Queen Elizabeth University Hospital, Glasgow. His research interest especially focuses on heart failure, the cardiovascular consequences of diabetes and chronic kidney disease, atrial fibrillation and the coronary artery disease, with a focus on the clinical trials and epidemiology. He was and he is the principal investigator, the member of the executive committee and the steering committee member in several large trials in his areas of interest. Basically, speaking of his awards and the accolades, he is a recipient of Stokes Medal of the Irish Cardiac Society. In June 2015, Professor John Mcmurray and Professor Salim Yusuf were jointly awarded the 8th Arrigo Ricordetti International Prize for the scientific research. And this particular prize basically is given for the outstanding contribution in the secondary prevention and risk reduction strategies in patients with cardiovascular disease. He is a recipient of Mackenzie Medal, which is awarded by the British Cardiovascular Society in recognition of outstanding service to British cardiology. He is a recipient of Lewis and Arthur Lucien Award for Research in Circulatory Diseases, which is awarded each year by McGill University, Montreal. He was awarded an OBE, that is Order of the British Empire. I mean, this is the largest ever recognition that anybody can ever get. So he was basically awarded the Order of the British Empire in 2019 by Her Majesty the Queen in recognition of his services to cardiovascular research. In 2020, he was awarded the Gold Medal of the European Society of Cardiology, which the society describes as the highest honor it can bestow on the exceptional scientists for their contribution to the cardiovascular medicine. He is the most highly cited researcher, and his Hirsch index is 200. I mean, many of you would certainly know what is Hirsch index. But Hirsch index basically is the impact of the scientist rather than the impact of the journal. So it is the impact of this. It is the impact of Dr. John Mcmurray, which is 200, which is unparalleled. And Dr. John Mcmurray today is going to speak on Dapagliflozin, the role in prevention and treatment of heart failure. Following his presentation, we will have Dr. Darren McGuire. He's a distinguished teaching professor of medicine, Dallas Heart Ball. He's a chair for research on heart disease in women. He's a lead physician in Parkland Heart Health and Hospital System Cardiology Clinic, University of Texas, Southwestern Medical Center, Dallas, USA. He's a clinical trialist with expertise in large-scale CV outcome trial design and execution, drug registration and regulation, with a focus in the area of diabetes and cardiovascular disease. He has had leadership roles for numerous international cardiovascular clinical outcome trials, including type 2 diabetes, obesity, and lipid trials. He is a previous member of the FDA Cardiovascular and Renal Drug Advisory Committee, and he continues to remain an FDA ad hoc consultant. He is a deputy editor of the journal Circulation. He is a senior editor of Diabetes and Vascular Disease Research. He is a co-editor of the textbook Diabetes, Cardiovascular Disease, a companion to Bromwald's Heart Disease. He is a vice chair of the AHA Diabetes Committee, and he has authored and co-authored over 350 peer-reviewed manuscripts, reviews, editorials, and book chapters. We also have with us, and of course, Darren McGuire is going to speak on Dapagliflozin, the role in chronic kidney disease in patients with or without diabetes.
Mr. Joshi, in the interest of time, I think you can skip my introduction.
We have Dr. Vijay Viswanathan. Dr. Vijay Viswanathan basically is a well-known, renowned diabetologist. His specific interest is diabetes and food, diabetes and kidney, diabetes and TB, and the socio-economic impact of diabetes. And basically, he has several awards to his credit. And I basically modestly take the advice of Dr. Vijay Viswanathan and then proceed to Dr. Hiremath. Dr. Hiremath basically is a director, cath lab, and the cardiologist of Heart Transplant Department, Ruby Hall Clinic, Pune. He is the pioneer of echo Doppler, PTCA, and heart transplantation in Pune for the first time. He is the chair professor of preventive cardiology. Of a monograph of coronary angioplasty, is the honorary editor of Circulation, which is the Indian edition. He is the principal investigator of many prestigious international trials like RELY and pulmonary arterial hypertension. His specialization is coronary angioplasty and heart failure, and his special contribution is in the domain of echocardiography and preventive cardiology. And is a teaching professor of cardiology in Pune Hospital, Bharati University to DM and DNB courses. So I once again welcome all of you, and I present to you Dr. John Mcmurray. Dr. John?
Well, thank you very much for that very kind introduction, which made me seem like somebody I don't recognize. I hope I don't disappoint people as a result. So I hope you can see my screen.
Yes.
And,
yeah, we can.
I'm just turning on my pointer so that I can point. So in this short presentation, I want to discuss the role of SGLT2 inhibitors in both preventing and treating patients with heart failure. And I will review all the new evidence that we have, which is actually a huge amount. These are my disclosures, and these are the drugs that we're going to talk about. I know that many people watching are diabetologists, and will know these drugs very well because they've been around for a few years, but to many cardiologists they're maybe not so familiar. Now, although these drugs were originally introduced as a treatment to lower blood glucose by blocking reabsorption of filtered glucose in the proximal renal tubule, they've become much, much more important. And they really are now drugs that have been repurposed to treat heart failure and repurposed to treat chronic kidney disease. They're really drugs that belong to many different groups of physicians and benefit a huge number of our patients with many different clinical problems. And we really have to think of the story of SGLT2 inhibitors like the story of ACE inhibitors and statins, how those drugs became really crucial to the management of so many people. But this is a story that has evolved in a much shorter period of time. So let's look at the first part of my presentation, which is prevention of heart failure. And this is really where we first learned about the role of these drugs, because in 2008, as many of you know, the US Food and Drug Administration required all new glucose-lowering therapies to demonstrate cardiovascular safety. So as a result, SGLT2 inhibitors in large cardiovascular outcome trials, and there were 4 of these trials that were conducted in a broad spectrum of patients with type 2 diabetes, patients who principally had risk factors all the way through to patients, all of whom had established cardiovascular disease. So 4 large cardiovascular outcome trials reporting in rapid succession, addressing really the whole spectrum of patients with type 2 diabetes. And these are the trials here. But strictly speaking, it's 5 trials because the canvas was actually a program consisting of 2 trials. You can see here that, as I said, some of the trials include patients with established cardiovascular disease, the DECLARE-TIMI 58. The majority of patients just had type 2 diabetes and risk factors. They were all huge trials. And this figure summarizes the results of all of these trials. So what I've done is I've put them all together, but I've ranked them not in chronological order, but in relation to event rate. So in all of these trials, the primary endpoint was what is frequently described as MACE, major adverse cardiovascular events. That's cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke, whichever of those events occurs first. And as you can see here, in all of these trials, MACE tended to be less common in the patients who got the SGLT2 inhibitor than in patients who got placebo. But all of the trials also reported heart failure hospitalization and the composite of cardiovascular death or heart failure hospitalization, either as a secondary endpoint or in the more recent trials, a co-primary endpoint. So if you look across all of these trials, so over here is EMPA-REG outcome, which had the highest overall event rate. To the far left of the screen, as you look at it, DECLARE-TIMI 58, the study in which most patients just had risk factors in addition to type 2 diabetes. They had the lowest rate of major adverse cardiovascular events. But if you look at all of these trials, you can see very consistently there was about a 30 to 35% relative risk reduction in heart failure hospitalization. Initially, something that was really not expected, but turned out to be an incredibly consistent finding in all of these trials. Now, there have gone on to be a number of other trials that allow us to look at prevention of heart failure in a different patient population, and that's patients with chronic kidney disease. Most of these trials, again, were, at least initially, only in patients with CKD and type 2 diabetes, but as you will see in a moment, the most recent of these trials, or one of the most recent of these trials to report, included patients without chronic kidney disease. Now, why is this of interest? Well, patients with chronic kidney disease have an extremely high rate of developing heart failure. And in fact, patients with advanced chronic kidney disease have something like a 30% annual incidence of heart failure. It's less in patients with milder degrees of chronic kidney disease, but it is an extremely common cardiovascular complication in these individuals. And again, amazingly, there are 4 more large randomized clinical outcome trials with SGLT2 inhibitors in patients with chronic kidney disease. The first of these to report was the Credence trial, stopped early because of overwhelming efficacy. Not going to talk about the renal outcomes. My presentation's about heart failure. But one of the pre-specified endpoints in this trial was the composite of cardiovascular death or heart failure hospitalization. You can see here this was reduced by 31%. That was a highly statistically significant risk reduction. Indeed, the risk of heart failure hospitalization was reduced by almost 40% in these patients with type 2 diabetes and chronic kidney disease. A second study I want to mention is a trial called SCORED. It used a drug called sotagliflozin. Now, sotagliflozin is actually a drug that inhibits SGLT1 as well as 2. It is a much more potent inhibitor of SGLT2, but it also blocks SGLT1, which is found in the gastrointestinal tract and is responsible for glucose reabsorption there as well. So SCORED was a trial using sotagliflozin. It was a very, very large trial, as you can see here, 10,500 patients. And there are various problems with this drug and with the 2 trials that were done with this drug. There was a funding issue. The sponsorship relationship between 2 pharmaceutical companies broke down and the trials were terminated early. But despite that, in this chronic kidney disease trial, you can see here once again that in fact, the primary composite endpoint, which was cardiovascular death or worsening heart failure events, not just hospital admissions, but also urgent visits with worsening heart failure, requiring treatment either in a clinic or in an emergency department. If you look at this broad composite outcome, once again, you see this very substantial reduction in heart failure hospitalization. But really the game changer in many ways was the DAPA-CKD trial, because this was a chronic kidney disease trial that included patients with and without type 2 diabetes. So this was the first CKD trial to enroll patients who didn't have type 2 diabetes. So DAPA-CKD was also stopped early at the recommendation of the Data Safety Monitoring Board, like the Credence trial. And we presented this trial last August. And again, I'm not going to show you the renal endpoint. That's not my topic, but I'm going to show you the pre-specified cardiovascular death or heart failure hospitalization endpoint. And here you can see again an almost 30% relative risk reduction. Indeed, there was an almost 50% reduction in heart failure hospitalization in this study. So now we're saying that SGLT2 inhibitors preventing the development of heart failure, not just in patients with diabetes, but in this trial also in patients with CKD who do not have type 2 diabetes. So Darren McGuire has actually put most of these trials together. This was a meta-analysis done before the DAPA-CKD and SCORED trials were presented, but the story is not going to be different. And the very important point I want to make here is that if you look at whether or not you study patients with type 2 diabetes and atherosclerotic or atherothrombotic cardiovascular disease, or without atherosclerotic atherosclerotic cardiovascular disease, you see a similar and significant reduction in the risk of heart failure and hospitalization. So these drugs are not just beneficial in patients with type 2 diabetes who've got coronary disease or have had a stroke, they also prevent the development of heart failure in patients who do not have obvious established atherothrombotic cardiovascular disease. And again, they also reduce that risk in patients with chronic kidney disease. So now let's turn to the other topic that I want to cover, and that is not about the prevention of incident heart failure, but the treatment of prevalent heart failure. So can we use those drugs also in people with established heart failure? And as you know, there are two, some people would say three, principal heart failure phenotypes, but there are those individuals who've got dilated hearts that are enlarged and contract poorly, and we call this heart failure with reduced left ventricular ejection fraction. There is another heart failure phenotype where the problem may be more about the relaxation and filling of the heart, and we tend to describe that as heart failure with preserved ejection fraction, and often that phenotype is of a hypertrophied, if anything, even small left ventricle as opposed to dilated large left ventricle. So in fact, what we know about is the role of SGLT2 inhibitors in the treatment of patients with heart failure and reduced ejection fraction, because that's where to date we have done our trials. And again, extremely importantly, just like DAPA-CKD, these were trials in patients with heart failure and reduced ejection fraction, both with and without type 2 diabetes. These were not diabetes trials, these were heart failure trials. And the first of those that we finished was the DAPA-HF trial. I presented this a couple of years ago at the European Society of Cardiology Congress. You can see here 4,744 patients, typical inclusion criteria for a HFrEF trial. You can see down here that 55% of patients did not have type 2 diabetes. And you can also see here that many of these patients had chronic kidney disease, about 41%, which is typical patients with HFrEF, and they were very well treated by conventional standards at the time. Once again, we saw a benefit, but now this is in secondary prevention as opposed to primary prevention. Heart failure, here's our composite outcome of cardiovascular death or worsening heart failure events, reduced by 26%, highly statistically significant, very small number needed to treat, very early separation of these Kaplan-Meier curves, indeed statistically significantly different within 28 days of randomization, remained significant thereafter. So this treatment is very effective and works very quickly. And really the story of this trial was, no matter what we looked at, there was generally a significant benefit, including in cardiovascular and in all-cause mortality. So this drug didn't just reduce heart failure hospitalization. In this trial, it also reduced cardiovascular death and all-cause death. The subgroups showed consistent benefits across all the subgroups that we looked at. It was very boring in that respect. Didn't find any interesting subgroup interactions. It was all pretty consistent. And of course, the most important subgroup to look at was the subgroup of patients without type 2 diabetes. And you can see here, whether you had no diabetes or you had HFrEF with diabetes, the hazard ratio was essentially the same. There was a 25 to 27% relative risk reduction with no significant interaction between diabetes status and benefit of dapagliflozin. In fact, we even found dapagliflozin was beneficial in people with a completely normal glycated hemoglobin level. But do compare the event rates in the so-called placebo groups. Remember, these are very well treated patients. And if you look at the diabetic patients compared to the non-diabetic patients, just look at what risk these patients are at. 24 months, about a 33% Kaplan-Meier rate. So if you've got HFrEF and type 2 diabetes, even if you're on good conventional therapy, you are at very high risk. And therefore, this relative risk reduction, which is large, translates into a very large absolute risk reduction. So these patients in particular have a huge amount to gain, but so do these patients. There's a very worthwhile benefit even in non-diabetic patients. But that's not the whole story, because again, in our amazing story of trials conducted in ambulatory outpatients, in other words, with heart failure, there's a second SGLT2 inhibitor trial that reported last year. That was the Emperor-reduced trial with a different drug in this class. And over here to the right of this figure, you see the results of Emperor-reduced. Their primary endpoint was slightly different than ours, but these are effectively the same, because most of our worsening heart failure events were heart failure hospitalizations, and you really could not get two more similar results. Incredibly consistent benefits, essentially the same hazard ratios, again, very similar Kaplan-Meier curves, this early benefit and sustained benefit over follow-up. Now, these drugs do other good things in patients with heart failure. I know we're going to hear about chronic kidney disease. We're going to hear about, and I've talked about, chronic kidney disease causing heart failure, but don't forget, patients with heart failure also develop chronic kidney disease. And actually, if you look at these two trials together in a meta-analysis, as Vijay and I did here in the Lancet, you can see that there was a substantial reduction in the risk of the kidney composite endpoint. This was a hard composite renal endpoint in these two studies. So these drugs also reduce worsening renal function over time. And lastly, what I haven't got time to go into, but I'm happy to do it in questions if you wish, is these drugs also maintain quality of life, improve symptoms, stop deterioration in symptoms and quality of life over time, and they do it remarkably effectively. And what's critically important here is that we've got two trials that show that, because that means the new guidelines will give these drugs a class 1 level A recommendation as a treatment for heart failure because of their remarkably consistent and substantial benefits. And then in DAPA-HF, just a couple of weeks ago, we reported, I think, another fascinating benefit of SGLT2 inhibitors. If you remember, I said 55% of our patients in DAPA-HF did not have type 2 diabetes at baseline. So, of course, in those patients, we could look at the development of new diabetes. And there are a few interesting things on this slide. The first is, you can see here that in the placebo group, around 10% of patients developed new diabetes within 2 years. So, although not really appreciated, heart failure is a very diabetogenic state. And as you can also see here, Dapagliflozin significantly reduced the risk of new onset diabetes by about a third, which is again quite remarkable. Now you might be thinking, well, that's because Dapagliflozin lowers blood glucose. Maybe the drug is just masking the development of diabetes. Well, let me just show you something to remind you that in patients who do not have type 2 diabetes, SGLT2 inhibitors don't lower blood glucose. That's why they don't cause hypoglycemia in patients who don't have type 2 diabetes. So this is not a masking effect. This is not, as far as we can tell, SGLT2 inhibitors just lowering glucose and preventing the detection of diabetes. This seems to be something else. And I just want to put those two heart failure trials into perspective, because I know that it's a mixed audience of cardiologists and diabetologists, and I sometimes think that people maybe think these trials are looking at the same patients and showing the same thing. And this slide is to try and illustrate that that's far from the case. So if we take DECLARE-TIMI 58, which was the trial in patients with type 2 diabetes and predominantly just cardiovascular risk factors, here is the rate per 1,000 person years of follow-up of heart failure hospitalization and of cardiovascular death or heart failure hospitalization. If you scroll to the bottom of this slide, so we're now looking at DAPA-HF, if you look at the rates in these patients overall, you can see here that it is literally a rate that is 10-fold higher. So these patients who've got heart failure are at a much higher, orders of magnitude higher risk than just a type 2 diabetes patient with risk factors. So these are extraordinarily high risk patients. They really are people who get an enormous benefit from this treatment, and that's why I really want to highlight the value of these drugs in treating patients with heart failure. Not saying that they're not valuable in these patients, but we're talking about a whole different ballgame when you look at patients who've got established heart failure. So to finish up with, I want to very quickly look at what some people say are still the questions that need to be answered about these drugs in patients with heart failure. So one of them, we always hear this, and I'm not really sure why, but it's always asked, is what about these drugs in hospitalized patients? What about so-called acute heart failure? And we have an answer to that, because last November, the American Heart Association, a sister study to the SCORED trial, this was soloist worsening heart failure, Darren was involved in this, and this was looking at sotagliflozin in type 2 diabetes patients who'd been hospitalized with heart failure, and they were randomized to receive sotagliflozin either during their admission or within 72 hours of discharge. And this, obviously, the patient profile was a little bit different. Clearly, more of these patients, when they were randomized, had more severe NYHA class. Very importantly, the average EGFR here was much worse than in the other trial, at least in reduced. And in SOLOIST, just as in the other SGLT2 inhibiting trials, you can see background conventional therapy was very good. And this is what happened. So remember, these patients were started either in hospital or within 72 hours of discharge. A relatively small trial, short average follow-up, but a very, very striking benefit. Again, there's very early separation of the Kaplan-Meier curves, the striking reduction in events. Now, this was a total events endpoint. It's a different type of endpoint than in the other trials, but very, very consistent with what we see in the other studies. So this treatment does work in hospitalized patients. In fact, if you look at the subgroup according to whether treatment was started before discharge, which was about half of patients, or after discharge, the other half of patients, the treatment effect was completely consistent. But why this trial is so important is because of what it tells us about safety. Because there is a lot of talk about the risk of these drugs in hospitalized patients in relation to diabetic ketoacidosis. And I know some of the endocrinologists, diabetologists are maybe more concerned about this than the cardiologists. But the SOLOIST worsening heart failure trial is very important from this point of view, because it was in many ways the canary in the coal mine test of this issue of ketoacidosis. Remember, all of these patients had type 2 diabetes. They'd all been admitted to hospital with decompensated heart failure. If there was any group of patients with heart failure who should have been at risk of developing ketoacidosis, these were the patients. And Here you can see what's happened in all of the studies. So in SOLOIST, there was no excess of ketoacidosis. Emperor reduced, there were no cases at all of ketoacidosis. DAPA-HF, we had 3 cases. They were all in patients with type 2 diabetes. In neither DAPA nor Emperor has a single patient without type 2 diabetes developed ketoacidosis. And again, to give you a perspective, here's the risk of angioedema with an ACE inhibitor or an epilystin inhibitor. And as you will see, the risk of ketoacidosis is actually as low or even lower than the risk of angioedema with an ACE inhibitor or an epilystin inhibitor. So that's just to keep this safety question, which is important to know about, but to keep it in perspective. So 2 remaining questions very quickly. HFpEF, well actually SOLOIST did include some patients with an ejection fraction of 50% or above. Small group, only 256 patients, but certainly very interesting subgroup analysis with a very favourable point estimate. In fact, the 2 sotagliflozin trials collected information about heart failure and ejection fraction at baseline, and in fact in the SCORED and SOLOIST trials put together, there were 739 patients with HFpEF. The bigger number, again, it's not definitive, but again, highly suggestive that this class of treatment might be doing something good, even in patients with that other heart failure phenotype. But we're going to get the definitive answer this year, because there are 2 dedicated large HFpEF trials underway. Emperor Preserved, which is around just under 6,000 patients. Deliver, which is our sister trial with dapagliflozin, is over 6,000 patients. These trials are both completed recruitment. Emperor Preserved is actually closing out and will report this year at the European Society of Cardiology Congress in September. We will be following shortly afterwards. So there are 2 enormous dedicated HFpEF trials that will give us the answer. And indeed, there are other acute heart failure trials underway as well. So we're going to have an astonishing evidence base for this family of drugs when we finish all of this in the very near future. Lastly, how do they work in heart failure? Well, I'm hoping you're going to ask Darren McGuire that question, because I don't know. Like everybody else, I've written articles speculating about how these drugs work. We truthfully don't know how they work. Although recently we have got some new evidence from 3 randomized trials showing that at least they're doing good things to hearts. This is one that we did. This was a cardiac MRI study. Patients were randomized to empagliflozin or placebo. You can see here we saw a reduction in left ventricular end systolic and end diastolic volume, a trend to improved ejection fraction, not significant. There is another study from colleagues in New York, smaller study, shorter follow-up, actually in patients without type 2 diabetes. So these were HFrEF patients without type 2 diabetes. You can see again reductions in left ventricular volumes. They saw this really amazing 5% increase in left ventricular ejection fraction. And then lastly, just published online very recently, a study from some Danish colleagues, an echocardiographic rather than cardiac MRI study like the last 2. So this was a bit bigger, and you can see here again, after a very short period of follow-up, only 12 weeks, significant reduction once again in left ventricular volumes, reduction in left atrial volume, and again a trend to improvement in ejection fraction, but not significant. But all 3 trials giving very consistent effects, and if you put them together in a meta-analysis, which we've done, you actually see all of these things improve. So to finish with, what's next? Well, watch out for these trials. They're currently recruiting, so 2 post-infarct trials. Fascinatingly, really moving the question now away from diabetes. Can we use these drugs to prevent heart failure, prevent cardiovascular death in patients without type 2 diabetes. So IMPACT MI is a high-risk MI trial, includes patients with and without type 2 diabetes. DAPA-MI is a very large acute MI trial, 6,400 patients. All of these patients are patients without type 2 diabetes. So we're going to find out whether these drugs are going to play an even broader role in secondary prevention of myocardial prevention of heart failure in patients with myocardial infarction. So in 2021, in heart failure at least, we have a very, very solid evidence base. Got 3 trials of drugs in this broad family, all showing incredibly consistent benefits, as you can see in this updated meta-analysis of the heart failure trials. No question these drugs in new guidelines are going to be part of the life-saving therapies that we will recommend as foundational therapy for all patients with HFrEF. There are 5 different pharmacological approaches. 2 of these can be given in one drug. That's an angiotensin receptor inhibitor. They call this the 5 Alive or the Fantastic 4, which the names that have been used. This is what we need to be giving our patients with heart failure and reduced ejection fraction. And it's a very, very large proportion of patients who are eligible for this treatment. So again, there are all sorts of implications, financial, workloads, resources, and so on, but this is probably what we have to do. So this is my final slide, and really the take-home messages, which I think are pretty obvious from what I've shown you. These are amazing drugs. They're a revolution in the same way that ACE inhibitors and statins were. They're going to become the standard of care in treatment of type 2 diabetes generally, treatment of chronic kidney disease generally, the treatment of HFrEF generally, and it may also be the treatment of HFpEF and perhaps even acute myocardial infarction. Thank you very much.
Thank you. For some reason, Dr. Darren McGuire has not been able to join us. So basically, we will proceed with the panel discussion. Dr. Vijay Viswanathan, there is a first question to you. I mean, this particular question as a background, the almost 60% of the Indians, especially they are diagnosed with diabetes at very early age, 20 and 45. This is the data that shows. And the problem is that these patients at the young age, they have to carry the risk of developing comorbidities because, they are going to live with diabetes for long. The second important problem is, it has been basically reported that almost 85% of the type 2 diabetic patients, when they visit the primary health care and when they are detected as being diabetic for the first time, they already have multiple comorbidities. I mean, your own report, Dr. Vijay Viswanathan, says that, almost 20% patients, have neuropathy, 15% have retinopathy, 10% patients have CAD, then almost 39% have heart failure, obesity, almost 56%, and dyslipidemia. And the problem is, basically the global data strongly indicates that diabetes patients, have high CVD burden, and it is responsible for 50% of deaths, of all the deaths of type 2 diabetes. Now, given this particular backdrop, and with a brilliant presentation of Dr. John Mcmurray, my question to you, doctor, is in management of people with diabetes in India, what do you think is the role of Dapagliflozin and how early you think the treatment should be initiated? Dr. Vijay Viswanathan?
Yeah, thank you, Mr. Joshi. I'll be very brief because I think most of the people in the audience would like to interact with Dr. John Mcmurray. So as you rightly said, people in India, especially from the rural areas or semi-urban areas, they come in very late. Once they are diagnosed with diabetes, they do not go to the physician or diabetologists immediately. They come after 3-4 years, by which time their EGFR is down, they have microalbuminuria, they have retinopathy, and as you very clearly said, they have heart failure too, and they have coronary artery disease. So I think in India, talking about India, I think we should start treatment, very aggressive treatment, that's what I mean, with dapagliflozin, basal insulin, whatever it might be, in people who are even newly diagnosed, because they already have had diabetes for about 6 years and already have microvascular and macrovascular complications. So I would like to just summarize my answer in one line.
Yeah.
Start the treatment aggressively with dapagliflozin, basal insulin, metformin as early as possible. Thank you.
Okay. There is a next question. Basically, diabetes is considered as equivalent of heart failure, and basically the pathomechanism underlying the progression of type 2 diabetes is found to be closely intertwined with the progression of heart failure. So the question is, at what stage of diabetes you recommend the patient should be screened for the early detection of heart failure, and which you think are the most reliable markers, which can be easily used by the doctors?
Again, I'll give you a brief answer. So, as you heard from Dr. John Mcmurray, there is a very close relationship between heart failure and diabetes. And the newly diagnosed diabetics, of which he was talking about among patients with heart failure, goes on to show that people with diabetes have increased prevalence of heart failure, and people with heart failure have more prevalence of diabetes, vice versa. So the thing is, people with diabetes have a lot of subclinical structural changes in the heart and function. And I think it's very important, like there is diabetes associated LV mass, there is diastolic dysfunction. So I think you should screen for the heart problems and heart failure very early at the time of diagnosis. We try to do microalbuminuria, we do foot test examination, we do an eye examination, retinal examination, all at the time of diagnosis of type 2. In type 1, you can wait a little longer. But in type 2, you should screen for all the complications of microvascular and macrovascular as early as possible at the time of diagnosis. And that's very important. And I leave it to the cardiologists. We diabetologists or endocrinologists do an echo. We can't do anything more than that. In our diabetes clinic, we have an echocardiography, a 2D echo. So we try to do that in all patients. We do a resting ECG, we do a treadmill. We diabetologists can't do anything more than that. So if there is something wrong, we refer to a cardiologist. Thank you, Mr. Joshi.
Yeah, I mean, basically, I would like to have the views of Dr. John Mcmurray on this question, because basically, as you have seen that, the onset of diabetes in India is almost, 1 decade earlier. At the time of diagnosis, they have the comorbidities. And even before, they are diagnosed, maybe 4 years earlier, 5 years earlier, they might be IGT patients. So at what stage, I mean, after how many years, after the first diagnosis of diabetes, John, do you think that they should be screened for heart failure?
That's a difficult question to answer. I mean, the way we do it here is that most of our patients with diabetes undergo yearly screening for all the things that you just heard about. And I completely agree. I mean, one of the most powerful predictors development of heart failure in a patient with type 2 diabetes is development of microalbuminuria. Yeah. And again, depending what study you look at, your relative risk of developing heart failure can be 10-fold higher once you start to spill abnormal amounts of protein into your urine. I agree with ECG, so left ventricular hypertrophy and an ECG atrial fibrillation on an ECG, very powerful predictor of future risk of developing heart failure. If you can do an echocardiogram, that's fine, although I don't think I would do an echocardiogram every year. I don't know a precise number of years you have to have type 2 diabetes before your risk of heart failure is particularly high. I think it's more to do with how well controlled your diabetes is and at what point you start to develop the complications of type 2 diabetes. And then your decisions about using treatment are really influenced by more about cost and cost effectiveness than anything, because I think what DECLARE-TIMI 58 taught us is that all patients with diabetes treated with an SGLT2 inhibitor will be less likely to develop heart failure than if they're not treated with an SGLT2 inhibitor, but the absolute risk reduction will be relatively modest in very low-risk patients, and conversely, it will be very large in relatively high-risk patients. And that's really been the story of everything we've done in medicine in the past, treating hypertension, treating hyperlipidemia. We've usually targeted the high-risk patients where you get a greater absolute risk reduction and more cost-effective use of therapy. And then as drugs become less expensive, generic, we tend to then allow their more liberal use. So I don't think there's any magical way to say who should and should not get treatment. But if you want to get the most value for your treatment, it's in those patients with type 2 diabetes who started to exhibit evidence of complications. Although obviously you could make the argument that it's a real pity to have to wait until somebody gets complications before doing treatment, but maybe that's the economic reality in many countries of how we use drugs.
No, doctor, that is antidepressant. Actually,
Thank you, John.
like
I mean, Dr.
antidepressant
Hiremath, would you like to
secondary
take a view on this?
I thought the factors like the left ventricular hypertrophy or the LVH on echo or atrial fibrillation, they all actually are pointers for diastolic heart failure. And we are not so sure about what's happening to that. I'm sure the trials are around the corner and we'll get the answer. But if you really want to prevent the systolic heart failure, reduced ejection fraction, then I think yearly echo is all that is possible to do. Remaining blood parameters, the BNPs and all don't help early. They will worsen only when the LV function decreases. So I feel the logical way would be to put every patient on a SGLT2 inhibitor once the diabetes is diagnosed and keep following them. And if they develop systolic heart failure or reduced EF, then of course then other things will follow. It's very difficult to diagnose reduced EF early or project. Whenever we talk of, I'll just say the last line again, the LVH, the LV hypertrophy, diastolic dysfunction, atrial fibrillation, all are pointers towards the elephant in the room, that is the diastolic heart failure.
You can take some additional calcium.
Thank you, Doctor. The next question is that, this DECLARE-TIMI 58 study, Dapagliflozin was studied in diabetic patients, all diabetic patients, but with or without ASCVD. Then in Dapah-HF, all patients were HFrEF patients, but they were with or without diabetes. And Dapah-CKD, basically the eGFR was in a range of 25 to 75. With or without diabetes.
Take it in the morning in empty stomach.
The question basically often is asked in India is, why this non-diabetic patient, when treated with Dapagliflozin, do not basically show hypoglycemia due to Dapagliflozin? Dr. Vijay Viswanathan?
Sure, definitely.
Yeah, I'll give you a brief answer once again.
Thank you.
So you must understand that SGLT2 inhibitors reduce blood glucose by reducing the proximal tubular reabsorption of glucose. independent of insulin secretion. Independent of insulin secretion. But it is not an insulin secretagogue like sulfonylureas or repaglinide and so on. It is also known that SGLT2 inhibitors increase gluconeogenesis, increase plasma glucagon levels in people with type 2 diabetes. You were asking about people without diabetes.
Yeah.
So having said that, there is a good review article by McGill and Subramaniam in the American Journal of Medicine in 2019, where they showed that if you combine SGLT2 inhibitors with insulin or sulfonylureas, the hypoglycemic prevalence of hypoglycemia is 40%. So by used by itself, it doesn't produce hypoglycemia. But if you use it with a secretagogue or with insulin, then your prevalence of hypoglycemia goes up. So to be very specific to your question, why in people without diabetes it does not produce hypoglycemia? Because it's not an insulin secretagogue. It's independent of insulin secretion. I'd like to know from John Mcmurray his answer.
I agree with everything you said like last time. But the only other thing I would add is that don't forget DAPA-HF and DAPA-CKD were very special populations. So in DAPA-HF, 41% of patients had chronic kidney disease because heart failure patients often have concomitant CKD. Obviously, 100% of patients in DAPA-CKD had chronic kidney disease, and the glucose-lowering efficacy of these drugs decreases dramatically when the eGFR falls. And that's why in many countries, in fact, before these new trials, you were not able to prescribe these drugs in people with an eGFR below 60 in some countries, below 45 in some other countries. In the UK, it was below 60, and if the eGFR fell below 45, then you had to stop the SGLT2 inhibitor. That was all based on these drugs being used for lowering blood glucose, but we don't believe that lowering blood glucose has anything to do with their benefits in heart failure or chronic kidney disease. So, of course, that's why we were willing to go to much lower eGFRs, 25 in DAPA-CKD, 20 in Emperor-reduced, because we weren't worried about loss of glucose-lowering efficacy, because we didn't think that that could be the explanation for how these drugs worked. So that's another reason why hypoglycemia was very uncommon, even among patients with diabetes. We had 4 cases of severe hypoglycemia in DAPA heart failure in each of the 2 treatment groups, but as just been discussed, they were all in people either on insulin or an insulin secretagogue.
Oh. Okay. So, thank you, John, Dr. Vijay Viswanathan, for this clarification. My next question is to Dr. Hiremath. This is over. Next question. Now, Dr. Hiremath, this ASCVD is the biggest burden in Indian phenotypes. And DECLARE-TIMI 58 study showed reduction in cardiovascular death and the hospitalization for heart failure in diabetic ASCVD patients. Now the question is, given the fact that such a high burden we are carrying in India of ASCVD, should as a protocol, Dapagliflozin be given to every diabetic ASCVD patient in India?
Yeah, the obvious answer is yes. Right now, recently there has been ample evidence related to this trial and others that, or we can call it a secondary prevention, if at all. If these are established ASCVD patients who are diabetics, then they need to be on SGLT2 inhibitors, because obviously we can prevent many things in them, not just the heart failure. And that's why I would very strongly recommend that all diabetics with ASCVD with or without heart failure should be on an SGLT2, especially dapagliflozin.
Yes, John. Basically, how would you? What is your take on this?
Well, so in an ideal world, which sadly we don't live in, but if we did live in an ideal world, I of course would want everybody with type 2 diabetes and atherosclerotic cardiovascular disease to be on an SGLT2 inhibitor. I'd also want them to be on a GLP-1 receptor agonist as well, because these two types of treatment probably have complementary benefits. But the reality is that I think that that's a very expensive prospect at the moment for many patients in many countries. So yes, I mean, that would be what you would aspire to. I completely agree. But I also know from talking to many colleagues in many parts of the world, that's unfortunately not possible for everybody.
Mm-hmm. But I think, given the fact that in India, the price of dapagliflozin is quite accessible to the patients now, at least to the large population.
I
So
was
I
about
see
to say that now in India, cost should not be a problem for dapagliflozin.
exactly.
That's amazing. That's brilliant.
So actually, we need not underutilize, dapagliflozin in diabetic ASCVD patients. We should try to basically give it to as many patients as we can to basically prevent the late complications of ASCVD with diabetes.
Well, I mean, it's a real shame we haven't had a chance to talk about kidney outcomes because they are as dramatic. I mean, in DAPA-CKD, we saw for the first time ever with any treatment for kidney disease, a significant reduction in all-cause mortality. It was astonishing. And I'm obviously a cardiologist. My interest is in heart failure, so we always talk about the dramatic effects on heart failure, but it was an equally dramatic story in chronic kidney disease, and in many ways a bigger story because there are so few other options for those patients. So it's a pity we haven't had time to review that because it is another fantastic, amazing parallel story that is just as important in its own way as the heart failure story.
Yeah. Dr. Vijay Viswanathan, would you basically like to give your views on this?
I think we have heard of this concept of pipe, pump, and filter. So it's a very funny concept. So I think they say that the GLP-1 receptor agonists are good for the pipes. The DAPA and so on is good for the pump and the pump and the filter. So I think in people with diabetes and atherosclerotic cardiovascular disease, what we diabetologists do is we try to combine SGLT2 inhibitors with a GLP-1 analog if cost is not a factor. The cost for GLP-1 is still very high in India. Many people can't afford it. Liraglutide and dulaglutide, all are expensive. So we try to discuss with the patient the benefits and try to combine it wherever possible. Thanks.
But at least the dapagliflozin benefit can be extended to the patient.
Yeah, true.
Yeah. Now, my next question to John is that next question. Now, HFpEF basically is believed to be the heterogeneous condition, and I think except diuretic, there are no international guidelines. There are no international recommendations which are there to manage HFpEF patients. But then today we see that as you also shared with us that DELIVER study, preserved HF study, determine and Stedia HFpEF. These are all studies which are likely to be published now. This current now very soon in the first quarter of this year, or maybe late this year and the middle of next year, Stedia HFpEF. Now, why so much of interest in basically assessing the effect of dapagliflozin in HFpEF patients? I mean, the question is, I mean, what is the clinical evidence, or what is the evidence-based, study-based logic supporting the use of dapagliflozin in HFpEF?
I suppose in many ways, SGLT2 inhibitors might have seemed a more obvious treatment for HFpEF than HFrEF, in that they result in some loss of weight, they result in some reduction in blood pressure, and of course HFpEF compared to HFrEF tends to be a more obese and hypertensive phenotype. And then of course SGLT2 inhibitors lower blood glucose, and HFpEF is a very dysglycemic insulin resistant state. So in that sense, SGLT2 inhibitors are attractive in patients with HFpEF. Patients with HFpEF, at least in some countries, tend to be a bit older, tend to have renal dysfunction a bit more than patients with HFrEF. And of course, SGLT2 inhibitors seem to reduce the risk of deterioration in renal function over time. So that's also attractive. And then there are a million other theoretical, hypothetical ideas about how SGLT2 inhibitors that may be equally relevant to HFpEF as HFrEF. For example, some people believe they may improve myocardial metabolism, energetics. That would also be relevant in HFpEF. So those are some of the reasons, but truthfully, it's like anything. Generally, when we've found a drug to be effective in one heart failure phenotype, we've rather perhaps naively immediately tried to assess it in the other heart failure phenotype. But I see Darren's joined, and he can tell you about SCORED and SOLOIST, because there was a subset, I think, in the two trials together, it was close to 750 patients who had heart failure and an ejection fraction above 50%, and the treatment effects seem to be similar in those patients. Now, it's not a definitive, it's not a large study sample, but it was certainly extremely encouraging. And as you said, we're going to hear, I mean, later this year, we're going to get the results of Emperor Preserved, and next year, the results of DELIVER. And between those two trials, it will be approximately 12,000 patients with HFpEF. So we will get a clear answer one way or the other. But Darren probably has a view in this.
But
hello everybody. Sorry.
Darren, welcome and good evening to you. I mean, we are delighted to see you here. Actually, you have been already introduced to the audience. So everybody was wondering where are you?
Well, maybe you've heard. In Texas, we've had a winter storm that has completely disrupted all of our utilities. We've had electricity and power outages and water outages, and my internet was not working this morning. So I am sorry to be so late to the meeting.
No, not at all. I mean, Darren, since, basically we are already discussing about HFpEF and all the various studies which are underway. I don't know whether John was sounding very optimistic about the outcomes of these studies, I don't know.
I thought I was being cautiously optimistic.
Yes. But Darren, what is your take on this?
It's interesting. My take has varied substantially over the last few years. As when we began these trials, I was very optimistic that HFpEF would be affected favorably by these drugs, the SGLT2 inhibitors in general and Dapagliflozin specifically. But then we started looking at the sub-analyses from IMPA-REG outcome and from Canvas, and we saw that most of the benefit was appearing to be in the HFrEF patients. So I became much less optimistic. But as John just mentioned, we've just completed the sotagliflozin trials, SOLOIST, with the dual SGLT1/2 antagonist, and it looks like, if anything, the magnitude of the benefit in HFpEF is at least as great, if not greater, than in HFrEF. And so I've again become optimistic that these drugs may favorably affect heart failure with preserved ejection fraction. And as John mentioned, we have the Dapagliflozin and the empagliflozin trials ongoing in selected patient populations independent of diabetes in heart failure with preserved ejection fraction. So I'm again optimistic, like John. I think we failed so many times trying to favorably affect heart failure with preserved ejection fraction, but at least from the SOLOIST data, it looks like we may have a winner in this class of medications.
HFrEF, yes.
By the way, my optimism pendulum swung exactly in the same way Darren's did over the past couple of years for exactly the same reasons.
Yeah. And now, the conventional way of managing HFrEF, has always been, use ACE inhibitor, ARB, ACE inhibitor or ARB, then add beta blocker, then add MRA. This is the conventional way of managing HFrEF. But John, your article in that circulation, December 2020, basically has created some ripples here because, basically it's a new sequencing of managing HFrEF patients, in which, you have proposed that hemodynamically stable patients, you can start with beta blocker and SGLT2 inhibitor, then add ARNI and then add MRA. Not necessarily each drug to be given in the maximum tolerable dose, but, rapidly after 1 week, keep adding maybe the small dose of each, but all 3 steps to be completed in 4 months. And then, having done that, then try to basically keep titrating the dose to the maximum tolerable dose. Now, Dr. Hiremath, first my question is, because there are a lot of discussions which are going on around this new sequencing. Now, what is the clinical or the evidence-based logic, for this new sequencing of managing HFrEF?
Okay. So, firstly, that article was written by myself and Milton Packer, and I have to say, Milton was really the one who thought of the very rapid, compressed, accelerated, trying to give all 4 treatments in 4 weeks. I was a bit more conservative than that, but I think we both came to the table, as many others have. There's nothing special, I think, about our thinking that, maybe the time has come to review the historical approach to starting therapy, because if you think about it, it's a sequence that's based on the chronology of the clinical trials. And I suppose if you take it to its logical completion, would have to be based on the concept that the most effective and best tolerated treatment must have been an ACE inhibitor, because that would be the only reason why you would suggest starting with an ACE inhibitor. And actually, the evidence just doesn't support that view. An ACE inhibitor is neither the most effective nor the best tolerated. So really, if you start to think about the evidence, we've got evidence that all of these drugs work independently. We know about the magnitude of effect. We know about the rapidity of their benefits. The dose titration steps is very important in terms of how you think about this. If you were to follow to the letter of the law some of the guidelines for a beta blocker, you start at 1/8 of the target dose and you up titrate every 2 to 4 weeks. So just to get somebody on a full dose of a beta blocker could take an incredibly long time. So really it was trying to consider all those permutations and what made sense in terms of getting the most effective treatments on board, The goal being to get all treatments on board as quickly as possible, and then what would be the most sensible way to do that. So beta blockers have the biggest effect on mortality, and they work very quickly. We know that for sure. SGLT2 inhibitors are probably the best tolerated of all the treatments we have. There's no dose titration involved. Their modest initial diuretic effect may help protect against any worsening that you get when you initiate a beta blocker, which actually people forget was actually seen in almost all the beta blocker trials, often requiring adjustment in diuretic dose. Thereafter, you could debate about the order in which the treatments are added, and then I suppose the other thing that took a little while to get our heads around was the idea of whether we could start and would advise starting 2 treatments at once. And in a way, that question was answered by sacubitril/valsartan, because that is 2 treatments, and we do these days quite often start that as a early or even first line therapy. So we thought, well, why you could give an SGLT2 inhibitor and a beta blocker together. The side effects of those 2 drugs are quite distinct, and you wouldn't be in any way confused as a practitioner. If a patient had a problem, you wouldn't have difficulty in figuring out which drug, if either of them was the cause of the problem. And then we were very pleasantly surprised to see, and Darren will know maybe more about this than I do, but the Journal of the American College of Cardiology had a group that produced a consensus view about the way in which we should sequence treatments in patients with heart failure and reduced ejection fraction. Interestingly, they also suggested starting 2 treatments simultaneously, except they chose sacubitril/valsartan and a beta blocker, but that was a huge step. So the suggestion to do 2 drugs together was a huge step also, because they said forget ACE inhibitors and ARB. Generally in 2021, if you're starting a RAS blocker, it should be coupled with an necrolysin inhibitor. So everybody's, I think, changing their thinking. I think we realize, I mean, the way I normally, you've heard me talk about it is, why is the diagnosis and treatment of cancer regarded as urgent in every healthcare system in the world, but the diagnosis and treatment of heart failure is not? And then Darren and I were doing a meeting, I think it was last weekend, and a diabetologist colleague from Denmark said something that I'd never heard before and thought was brilliant, which was, she said she regarded not giving an SGLT2 inhibitor to one of her patients with diabetes as like not giving chemotherapy to a patient with cancer. You just wouldn't do that and wouldn't think that way. So again, I mean, our article was deliberately meant to be provocative and try and get people talking and thinking about it. But those were the goals, really, was to get people thinking about, we need to do this, we need to do it quickly. The trials shouldn't tell us about the order in which we should give drugs. These tell us about what drugs are effective, and that if we can find a better, faster way to do it, that's what we should be trying to do. And it was really not much more than trying to get that conversation started.
Dr. Hiremath, would you like to take a view on this? Because this is very important, critical.
Yeah, I think finally, when a patient who is in reduced heart failure at the end of maybe a few months would be on all 4 drugs. But the 2 starting together is, idea probably is both are not hemodynamically acting drugs. Like if you put a beta blocker and an ERNI together, probably side effects related to hemodynamics and other things would jeopardize the treatment that follows. So it's a good idea to have a hemodynamically active drug like beta blocker, and not so hemodynamically but acting through other means drug like SGLT2 inhibitor to start with. Obviously, we are talking of stable patients, so diuretics don't feature there so much. So it stands to logic that these two drugs started initially, and then of course you take it from there. So what to add next, and maybe Ernie would be on board for every patient. So just like it is said about chemotherapy for cancer patients, I would say that every heart failure with reduced EF should be or must be on a beta blocker, a Ernie, SGLT inhibitors, and an MRA. So that completes the treatment and gives the maximum benefit. In fact, we've had patients getting out of the heart transplant list once they could achieve these doses very well, and they could show significant improvement in their even ejection fractions related to this full scientific treatment.
Yeah.
I wanted to ask a question to Darren. Supposing you have a person with severe heart failure and sepsis in the foot, no peripheral arterial disease, would you be bold enough to use an SGLT2 inhibitor in somebody? We had 2 such patients in the last 1 week in our hospital. Severe heart failure, the surgeon could not operate the foot. So, we had to control his heart failure before doing a wound debridement. So would you recommend using a SGLT2 inhibitor in somebody with heart failure who has got sepsis in the foot?
Yeah, it's a great question, and independent of heart failure, I do think we should avoid these medications during active infection, specifically diabetic foot complications. When we saw in Canvas, we saw the amputation signal, and then now we've drilled down into the DECLARE data set and published it. Appears that all of the imbalance in amputation with these class of medications are associated with infections and not necessarily with arterial, with blood flow problems. And so in the Credence trial, the subsequent trial of Dapagliflozin, there was a protocolized evaluation of the feet at every trial visit and an interruption of study drug during active infection or active diabetic foot complication. And using that mitigation strategy, there was no imbalance in credence in amputation or fracture, for that matter, with Dapagliflozin. So I think all of these drugs do have a small, manageable risk for soft tissue infections, and so I think it's prudent to interrupt the drugs or avoid them during active foot infection. But I'll also say I don't think we should avoid them in patients with peripheral arterial disease. For all of the atherosclerotic cardiovascular outcomes trials across the class, PAD, peripheral arterial disease, was an inclusion criterion, and the patients with peripheral arterial disease actually had, if anything, an exaggerated cardiovascular benefit. So arterial disease in the periphery in and of itself is not a contraindication, but to your point, I think active diabetic foot complication is a time to avoid the medications.
Thank you, Darren.
I would also be cautious. Although I've advocated using these drugs even in a patient who's got over their immediate decompensation when they're hospitalized with heart failure and starting treatment before discharge, and I know that that's raised questions from often the endocrinology community about diabetic ketoacidosis. I would also be cautious about using these drugs, either starting them or continuing them in somebody with heart failure who's got some concomitant problem requiring treatment, like an infection, because that's the sort of situation where people's fluid intake may be reduced, and especially if they're on insulin, that's the sort of patient where you can get into trouble. So I think if somebody's got active sepsis, probably anywhere, Darren, that's one to be a little careful about, I would have thought.
Yeah, I agree. Anybody who's not only have their food intake interrupted, but also are in an acute catabolic state, I think the risk of DKA is manifest even in type 2 diabetes in those patients. So the few days to avoid the SGLT2 inhibitors while you get a patient compensated makes a lot of sense to me.
Yeah. Now, John, I mean, basically, in your presentation, you alluded to two important studies, these impact MI and DAPA-MI, especially for those patients, who post-MI, post-revascularization, may develop heart failure after discharge. Now, basically, how do you stratify the high-risk population? I mean, because, there will be, at the time of presentation of MI, there could be heart failure. Or after revascularization, when the patient is in the hospital, he develops heart failure. Or after discharge, he develops heart failure. So, how do you stratify the high-risk population so that, if not in the hospital, but at least, at the time of discharge, you anticipate, the patient might basically progress into heart failure, and then preempt by giving Dapagliflozin to the patients?
Okay, so first of all, I think if you've got type 2 diabetes and you've had an MI, then once you're over that acute event, I don't know when that is, 4 weeks, 6 weeks, or whatever, you're eligible for treatment with an SGLT2 inhibitor. And that's the problem I have with one of the two acute MI studies that are ongoing. So the DAPA-MI trial I have no problem with because it is a trial conducted exclusively in people with type 2 diabetes. And they're defining high risk in a very simple way, which is an ejection fraction less than, I think it's 50%, or a Q wave myocardial infarction on the 12-lead ECG. So Q waves, we don't talk about MIs in that way much these days, but old-fashioned Q wave myocardial infarction. And inevitably, that's a big trial because those patients, although they are at higher risk than all survivors in acute coronary syndrome, very few patients with an acute coronary syndrome these days really are at exceedingly high risk, like, for example, heart failure patients with type 2 diabetes are. So that's how it's being done in one trial. The other trial, the empagliflozin trial, the EMPACT-MI trial, that's a different trial, so that's about half the size. It includes some patients with type 2 diabetes. And that's what I'm not sure, I'd be interested to hear what Darren's view about this is. Not sure how it's justified to have those patients randomized to placebo, but they're looking at high risk in terms of all the things that were used in the early ACE inhibitor trials and the Valiant trial with valsartan. So things like reduced ejection fraction, transient pulmonary congestion at the time of infarction, need for diuretic therapy, and a few other recognized predictors. Atrial fibrillation, I think, is one of them, of increased risk of developing heart failure after the acute event. Because, of course, what these trials have tried to do is to enrich for the one event that we know these drugs are very good at reducing substantially, and that's heart failure. So they tried, it's not high risk of anything, it's high risk specifically of heart failure. So they tried to pick inclusion criteria that particularly elevate the risk of that specific cardiovascular complication.
So you also, I mean, basically obliquely you suggest that a diabetic patient, if we suppose MI, we can take it for granted is a high-risk patient.
That's my view and what I actually practice.
Okay, Hiremath,
if somebody's come in with an acute MI, if I don't send them home on an SGLT2 inhibitor when they come back to the secondary prevention clinic, we definitely start them on a SGLT2 inhibitor if they've got type 2 diabetes. Obviously, if they don't, then we don't know. And that's why I think the DAPA-MI trial is a very relevant and very good trial. And that's really the final frontier, I think, with these drugs, is to find out whether they're like ACE inhibitors or statins can be used in a broad spectrum of patients with atherothrombotic disease. But again, Darren, I mean, what do you think, or what do you do?
Yeah.
I agree completely. You know,
Yeah.
we have the privilege. I work in a closed healthcare system, the Parkland healthcare system in Dallas, Texas, and we have a closed formulary. And fortunately for us, our formulary, our P&T committee has approved SGLT2 inhibitors and GLP-1 receptor agonists unrestricted. So in our cardiology division, we are routinely discharging patients from acute coronary syndromes on SGLT2 inhibitors when they have type 2 diabetes. And to your point, John, I think it's incredibly important to investigate the broader population of all comers with acute coronary syndrome. I'm involved in the DAPA-MI trial, and I'm very optimistic that, independent of diabetes, that post-myocardial infarction, that these drugs should be beneficial. I wouldn't have said that before your DAPA heart failure trial and before the Emperor Reduced trial. I was a little bit skeptical that these drugs would work in the absence of hyperglycemia, in the absence of glomerular hyperfiltration. But now we've seen from 2 heart failure trials and from the DAPA-CKD trial that the cardiovascular and the kidney benefits appear to be independent of diabetes. And so I'm very optimistic in a post-acute coronary syndrome patient population independent of diabetes.
Your optimism pendulum's definitely been swinging.
I tell you, it's what I've figured out, John, is that there's no patient population these drugs don't work.
Dr. Hiremath, tell me, what is your take on this?
It's true. I think data will show whether it is to be used or not. But logically, as if now without the data, I feel there's no harm in starting them on SGLT2 while they are going home.
Yeah. So that makes that will make a difference. Darren, actually, you were scheduled to speak on CKD, but of course, we have been basically logged in for last almost hour and 45 minutes. But would you like to give some important take-home messages with regards to?
Yes, and again, apologies and for the technical difficulties.
We understand your problem. Yes.
So the bottom line is for CKD, whether it's diabetic chronic kidney disease or CKD from other etiologies, these drugs, the SGLT2 inhibitors in general, and Dapagliflozin specifically, have been proven now. Dapagliflozin is the first drug to be shown independent of diabetes to favorably affect kidney disease progression. And it's a remarkable stabilization of kidney disease and kidney function, independent of where you start. If you start completely normal in DECLARE-TIMI 58 and in DAPA-CKD, the healthier patients stabilize, the mid-range patients stabilize, and the most advanced patients stabilize. And so, and this is stabilizing the progression of decline of EGFR, which is predominantly driving the kidney benefits. And we've seen this across the class. It's not just Dapagliflozin, but the data, at least right now, for non-diabetes patients is only exists for Dapagliflozin for the DAPA-CKD trial. But it's remarkable, and it does raise the possibility that if we start early, we could mitigate almost completely the risk of diabetic kidney disease. In the cardiovascular outcomes, it's interesting that we see the cardiovascular benefits of this class of drugs in general and Dapagliflozin. Specifically, the benefit is magnified as kidney function wanes. And so if the worse the kidney function, the greater the benefit for heart failure outcomes and the greater the benefit for atherosclerotic cardiovascular disease. The opposite is actually true with kidney function, that the more healthy you start, the more you stabilize early on. And so there's a real chance that these drugs can, if not eliminate altogether, markedly reduce the risk over a lifetime of developing diabetic kidney disease. And so it's a really in parallel with the heart failure outcomes, it's a really intriguing phenomenon that we can so powerfully affect kidney outcomes.
Yeah. Thank you, Darren, and I very sincerely thank John and Darren for joining us today. I think
especially Darren, given that Texas has been absolutely not close.
We can put a rover. We can put a rover on Mars, but we can't provide electricity to our houses in Texas.
Darren, I thought you had just gone to Cancun.
I need a bigger beard to get Cancun.
Yeah, and maybe I think we will, Darren, we will catch up with you again sometime.
Yes,
yeah.
I owe you one.
Yeah. So basically, we will more than compensate for what we lost this time.
Yes.
Yeah. So thank you very much, John and Darren, for being with us. I mean, basically, these interactions have been extremely enlightening and very enriching for all of us. And these interactions really helped in clearly delineating the clinical situations where dapagliflozin could be of immense help and would improve the clinical outcomes. And I must sincerely thank Dr. Vijay Viswanathan and Dr. Hiremath also for being with us, because they also added a lot of value. And I also thank all the attendees who basically are present with us, and I'm very sure that they have been immensely benefited with these particular interactions. And I think some of the articulated questions or unarticulated questions must have been already answered by now, and I think they will be more generous in using dapagliflozin to the patients to improve the clinical outcomes in certain defined clinical conditions. So I wish, I once again thank you all, and I wish a very pleasant evening ahead to all of you, and I wish you good night. Thank you very much. Thank you, sir. Thank you. Bye-bye.
Bye-bye.